بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وأصحابه أجمعين. السلام عليكم ورحمة الله تعالى وبركاته. I'm so delighted to make the launch of this academic initiative, bringing together Sudanese pediatric worldwide to promote collaboration, share knowledge, and advance child health care in Sudan for the benefit of pediatricians, children, and future generation. من أجل أطفال السودان، ومن أجلي، ومن أجلكم، ومن أجل أبنائي. I extend my sincere appreciation to Dr. Abdelhadi Abdeljabbar Abdelhadi for his long-standing contribution to fostering academic and professional cooperation among physicians. And I congratulate our colleague in Sultanate of Oman on the start of this promising journey. So the initiative to be from Oman, that is wonderful. May Allah bless this initiative and make it source of benefit for pediatricians and children in Sudan. And at this juncture, I would like to turn on the microphone and to transfer it to our colleague, Dr. Ahmed, who is a consultant in neurodevelopmental for children from Sultan Qaboos University and Hospital. So, Dr. Ahmed, now the mic for you, and thank you very much.
السلام عليكم ورحمة الله تعالى وبركاته. Thank you very much, Dr. Kareem, for having this initiative, and would like to thank all of you for attending this very important initiative and sessions. Distinguished colleagues, good afternoon. I would really like to welcome you on this session from Sultanate of Oman. This session is devoted to Triple A syndrome, which is known as Algroff syndrome, which is a rare disorder whose clinical and genetic dimensions we will explore together in discussion to flow. There are few people in this world are better placed to open that conversation with you. One of them is our speaker today. It's my privilege to introduce Dr. Selwa Abdelbagi Hassan, who is a consultant pediatric endocrinologist at the Medical City for Military and Security Services in Sultanate of Oman. And she is an associate professor of pediatrics at the Adrenal University at Sudan. Dr. Selwa has been trained through her MBBS, MD, MRC, PCH, and PATCA fellowship pathway. And Dr. Selwa has built a career that few can match, from its build of scientific rigor, clinical dedication, and generosity of services. Much of that career has been given freely and tirelessly to children who might otherwise have no one. As General Secretary of Sudan Society of Pediatric Endocrinology and Diabetes, as a clinic supervisor and life for child program coordinator with Sudan Childhood Diabetes Association, she has helped keep care flowing to vulnerable children through some of the most challenging conditions imaginable during that very tough humanitarian crisis. That commitment extends across the continent and beyond. She led the CAH, and DSD focus group of the African Society of Pediatric and Adolescent Endocrinology and the African CAH DSD Research Network. She served on executive committee on the Global Pediatric Endocrinology and Diabetic Society and sit on the steering committee on the International IDSD and ISDM Rare Condition Registries. Hers is leadership that built capacity, open door for young colleagues, and insist on excellent endocrine care is possible even where resources are scarce and during humanitarian crisis. Talking about Dr. Selwa's scholarship, her scholarship speaks directly to today's theme, Dr. Selwa is the lead and corresponding author to a paper published on Frontiers and in Endocrinology in 2025, which assembled one of the largest comprehensive cohort on AAA patients reported from sub-Saharan Africa and Arab countries, bearing that scale with detailed clinical phenotype characterized that describe newly reported features of the syndromes and identified a greater number of genetic mutations than previous regional studies. This work sits within a wider research program on adrenal insufficiency in resource-limited setting, including her paper in European Journal of Endocrinology on a novel recurrent mutation in genetic diversity in Sudanese children. In Dr. Selwa, scientific leadership and humanitarian commitment meet in a single, inspiring career. Please join me to welcome Dr. Selwa to this session. Thank you very much. Dr. Selwa, the mic is yours.
Thank you very much, Ahmed. Thank you very much for this introduction. I'm not sure if I deserve all that, long introduction, but thank you very much. And I'm really honored today to be here with my distinguished professor, my colleagues, my juniors, my resident. Thank you very much for being here today. And I'm really happy to be starting the first session in this platform. And it gives me a huge, huge pleasure to be here today to present one of the uncommon, not rare, uncommon condition, especially in Sudan. So thank you very much for the introduction. Thank you for colleagues who accepted the invitation to be here today with me today. Thank you very much. So I'm gonna start my presentation. Just a minute. So can you see the screen?
We can see your first slide.
Okay. So my presentation would be regarding the connecting clinical, just a minute. Okay, so connecting multi-system clinical clues for early recognition of primary insufficiency in children and the lesson learned from a rare syndrome. So it's me, Selwa Abdelbaki. I'm a pediatric endocrinologist currently working in Oman. So the outline of this presentation would be an overview about primary adrenal insufficiency, which is the main condition, and then we'll go through some case scenarios to discuss the clinical clues regarding this syndrome, and then we'll share our experience from Sudan and what are the lessons learned. So as you all know that Addison was the first one to link adrenal dysfunction to specific clinical syndrome in 1850. And he described the syndrome of hyperpigmentation due to adrenal gland destruction. And then he's not the one who named this syndrome as Addison, rather it's Troze who named it Addison disease. And it took around 150 years until making significant progress in the knowledge of primary insufficiency. And only just recently, around 45 years ago, when CAH was raised into consideration. So primary insufficiency, specifically in children, is an uncommon clinical disorder. And it occurs mainly due to impaired secretion of glucocorticoid plus minus mineralocorticoid hormones from the adrenal cortex, either due to adrenal destruction, dysfunction, or congenital absence. It has very challenging diagnosis due to its non-specific presentation, and it has many common etiologies, including congenital adrenal hyperplasia, genetic etiologies, autoimmune causes, and infectious causes. But here we can say that CAH and genetic causes outweigh the autoimmune one in children compared to adult population. So you can see here, if we want to classify the etiology of primary adrenal insufficiency, we can classify them into adrenal steroidogenesis disorders. The most common is congenital adrenal hyperplasia, or adrenal dysgenesis disorder like congenital adrenal hypoplasia, or familial glucocorticoid deficiency, or what we call ACTH resistant syndrome, which is the main topic for presentation today, like FGDs and ACTH and AAA syndrome. And then we have the cholesterol synthetic defects like hormone disease and others, metabolic causes like adrenoleukodystrophy, and autoimmune causes, including isolated Addison or autoimmune polyneuropathy syndrome type 1 or type 2. So the clinical presentation of primary insufficiency is usually non-specific in children. It includes fatigue, vomiting, nausea, abdominal pain. That's why it's very non-specific. It has also symptoms related to glucocorticoid deficiency plus minus mineralocorticoid deficiency, and it has also symptoms related to specific disease and diagnosis. So if we can compare acquired adrenal insufficiency compared to the primary adrenal insufficiency, we can see that acquired one has an insidious onset, while the congenital adrenal insufficiency or primary adrenal insufficiency has an early acute presentation. And we don't forget the hyperpigmentation, which is the main clinical features that differentiate between primary adrenal insufficiency and secondary adrenal insufficiency. So why I choose this topic for presentation today? Actually, I have two main reasons. I will speak about the first reason. I'll keep the second reason for the mid of the presentation. The cause behind choosing this topic is that presentation of primary insufficiency in Sudanese children could be masked by many other common diseases in the community, like gastroenteritis, malaria, and others. And then data from Sudan suggests that different etiologies of primary insufficiency compared to global published data. And also early recognition of these symptoms related to primary insufficiency in children could prevent certain severe complications frequently encountered in undiagnosed cases. So as we all know that Sudan is a big country and has 45 million population before the war, and it has numerous African and Arabic ethnic descent groups, and there is diversity in these ethnic groups, and it has high rate of consanguinity, making the autosomal recessive disease very prevalent, and it could reach sometimes 70 or 80%. So this is the Jafar ibn Auf Hospital, the main tertiary hospital before the war. ندعو الله سبحانه وتعالى إنه يردها إلينا. And this is the pediatric endocrinology ward at Jafar ibn Auf Hospital, and this is where all stories begin. So just for the history, I remember when I first spoke to Prof. Ahmed Abdullah about why not to collect our cases of non-CH primary insufficiency as a part of my thesis in the fellowship. And he supported a lot, and we started collecting the cases of non-CH primary insufficiency. And as you can see, we have found that the Algrove syndrome or Triple A syndrome account for more than 40% of the cases, while other cases include autoimmune and other causes. So in 2020, we published this series, a large cohort of clinical profile etiology and diagnostic challenges of pediatric primary insufficiency, and we shared our 14 years experience from resource limited setting. And when we published that series, we found that the main cause of primary insufficiency after CH is Algrove syndrome. And as you can see here, Algrove syndrome accounts for 40% of the cases of primary insufficiency in children, apart from CH, while 40% of cases has unspecified diagnosis. So in that series, we found that symptoms and presentation are very vague, including abdominal pain, fatigability, poor weight gain. And we found that the hyperpigmentation is the main cause or main symptoms are presentation of patients with primary adrenal insufficiency, which is sometimes difficult to be assessed in dark skin population. That was followed by abdominal symptoms. Again, it's very vague. And adrenal crisis or hypoglycemic crisis account for 25% of cases at diagnosis. We have looked into what are the initial diagnoses at first presentation, and we found that 50% of cases has completely different diagnoses at presentation, including gastroenteritis, malaria, and gastroenteritis, malaria, and meningoencephalitis. And you can see that that's lead to due to indicate professional unawareness about this condition due to disease and specific presentation. If we looked at the family history, we found that 77% consanguinity rate in this series, 50% actually, half of the patient has similar condition in the family, and 40% of the cases had death of one or two or more siblings at the time of the presentation with similar condition. And this reflects the importance of early diagnosis and prevention to prevent serious complication and even death. Okay, so let's go through some case series to explore more about this condition and its presentation. So we'll start by this case. So this is 2-year-old male who presented with fever, diarrhea, and recurrent convulsion for 3 weeks duration. And he has frequent admission with similar attacks in the past, usually attributed to different diagnoses as we mentioned, including meningoencephalitis and cerebral malaria. He has unfortunately family history of 3 siblings deaths with similar presentation. and all has dark color noticed in all siblings. And he was diagnosed this time as meningoencephalitis. So if you can see here that the child is very dark compared to his mother hand, he's blind with frequent seizure, he's not dysmorphic, and had normal genitalia. The workup revealed normal initial workup, and due to this convulsion in this child and he's blind, MRI brain has been done and revealed bilateral some white matter changes. So let's go to connect all these clinical clues so as to reach the final diagnosis. So this child has recurrent seizure, some attributed to hypoglycemia, and he had significant family history of early sibling death. And he also has hyperpigmentation in the child and other diseased children, which is highly suggestive of adrenal insufficiency. That was supported with very low cortisol and high ACTH at presentation, but he has MRI features suggestive for leukodystrophic changes. So this child could be adrenal insufficiency due to adrenal leukodystrophy, but the early presentation of this child and other clues direct us towards other etiology, which is normal electrolytes. So this child presented only with glucocorticoid deficiency, while the electrolytes was normal presentation. So let's put it all together. So if the child presents with afebrile seizure, we have to rule out the hypoglycemic seizure. And if the child is having hypoglycemia with salt loss and hyperpigmentation, this is highly suggestive of primary insufficiency for whatever etiology. If this child presents early and he's a male, we have to exclude CAH because, as you know, the CAH or congenital adrenal hyperplasia presentation in a male is usually very difficult because of normal genitalia. So if this child is also a male and he had primary insufficiency and MRI change suggestive of leukodystrophic change, this could directly point it towards adrenal leukodystrophy diagnosis. But in this child, he has hyperpigmentation, severe hypoglycemia indicate glucocorticoid deficiency, but there is no salt loss. And this could give a clue of ACTH resistant syndromes, whether familial glucocorticoid deficiency or Triple A syndrome. So this child has proved to have familial glucocorticoid deficiency, which are a group of disorders due to impaired cortisol production, leading to hypoglycemia and seizure. And mineralocorticoid deficiency is an unusual feature of this syndrome, but sometimes it has been reported in some cases of FGDs. Presentation usually is usually in infancy, unlike the other causes of autoimmune adrenal insufficiency. Patient has severe hyperpigmentation at diagnosis because of the ACTH resistance. And treatment usually is replacement doses of glucocorticoids, but sometimes we have to point that supraphysiological doses of steroids to suppress the ACTH should be avoided, because sometimes when those patients present, physicians tend to give them high dose of steroids so as to suppress the ACTH, but we want to clarify that ACTH won't be suppressed in these conditions, so we just need the physiological dose of steroids. And long-term neurological consequences of FGD can vary, and the etiology actually it could be due to severe hypoglycemic seizure, which could affect the brain, or other etiologies which are not explored yet. So here are some types of familial glucocorticoid deficiency types, and there are many types actually, and every day there are many reported new FGD types. In Sudan, we have MC2R mutation as one of the commonest type of FGDs, and we have NNT mutation as one of the commonest type in Sudan compared to other population. So if you remember, when we first explored our cases of primary insufficiency, we found that the Algrove syndrome account for nearly 40% of cases, but we had 40% of cases with unspecified diagnosis. So that's why we collaborate internationally with University of London, William Harvey Institute to make a direct testing for other cases which had unspecific diagnosis. And we have found that the FGD account for a good number of patients, and it could be the third cause of adrenal insufficiency after CH and Algrove syndrome or Triple A syndrome. So the message from this case is always think of hypoglycemia in any child present with afebrile seizure, and this specific for the resident, and think of FGD or ACTH resistant syndrome in patients with glucocorticoid deficiency only when the salt loss has been preserved. So let's go for the other etiology of ACTH resistant syndrome, which is Triple A syndrome, because it's most common etiology of primary insufficiency in our setup. So Triple A syndrome or Algrove syndrome, it's a clinical multisystem disorder, and it was firstly reported by Algrove et al. In 1978, where he discovered 2 patients with Algrove syndrome. It has autosomal recessive inheritance due to mutation in what we call AAS gene, which is indicate achalasia, Addisonian, and Elacrima syndrome, encoding the aladdin protein of MPC, Elacrima aladdin, pointed to Elacrima, achalasia, adrenal insufficiency due to adrenocorticotropin hormone insensitivity and neurogenic disorder. It was previously called 3A syndrome, but due to other feature of this syndrome, some pointed that it should be 4A syndrome due to neurological dysfunction reported in this syndrome. So regarding the genetics of this syndrome, the AS gene encodes the aladdin protein, as we previously mentioned, and aladdin protein is localized at the nuclear pore complex, which mediate the transport of the macromolecules from cytoplasm and nucleoplasm. And it play a role in cell division, cytoplasmic trafficking, peroxisomal function, and oxidative stress effect. There are more than 70 mutations reported to date regarding Algrove syndrome, and some other genes, like 2 other genes, new genes have been encountered in this syndrome, and it has recurrence risk of 25% because it's autosomal recessive, and prenatal diagnosis through chorionic villus sampling is available, but of course not in Sudan. So the pathophysiology of this syndrome is not yet elucidated, but it was thought that aladdin mutation lead to misintegrating of the protein in the nuclear pore complex, and it lead to impair of nuclear importation of DNA repair protein, which are involved in nuclear defense against oxidative stress. That makes the cell susceptible to oxidative stress, resulting in selective tissue degeneration. And the high expression of this protein in certain cells in the body, including adrenal gland, brain, and gastrointestinal tract, and the organ, which is the main pathogenic manifestation of disease occur. So regarding the clinical presentation, actually age of presentation is very variable, with elacrima, which is the first feature of this syndrome, presented in early infancy, while achalasia varies, it could present from 6 months to early adulthood. And ACTH-resistant adrenal insufficiency, not present at birth, but developed over time. So the above complete triad is present in 70% of cases, and autonomic dysfunction has been reported in just 1/3 of the patient. And actually in Triple A syndrome, the phenotype is very complex, and all clinical features are progressive, suggestive degenerative process. So if we want to look at the feature of this syndrome, it's to explore how it is like multisystem disorder. Patient with Algrove syndrome or Triple A syndrome usually present with this marked feature, including narrow face, long philtrum, and downturn mouth. And you can observe that these features can be observed in most of the cases of Triple A syndrome. They have ophthalmological features like elacrima, hypolacrima, optic atrophy, and others. And also they have oral and dental manifestation, include dental caries and xerostomia and fissure tongue. They have GIT manifestation, including achalasia, dysphagia, among others. And also they have neurological manifestation, including both these systems. It also has sensory impairment, including sensorineural difference, microcephaly, dental retardation, and dementia. They have other autonomic features, including postural hypertension, among others. And also they have endocrine manifestation, which are the main features, including glucocorticoid deficiency, which is the most common, while melanocorticoid deficiency are very rare. Short stature, osteoporosis, among others. And also they have dermatological manifestation, include hyperpigmentation, palmoplantar hyperkeratosis, and cutis and cerning. So diagnosis of this syndrome is very challenging, despite it has a very clear clinical feature. But what we need to diagnose this syndrome is just 2 out of 3 cardinal features, which is suggest diagnosis of Algrove syndrome. And the most frequent initial presentation usually is hypoglycemic seizure. So usually elacrima is not missed at the time of presentation, but most of the patient had previously recognized elacrima at the time of presentation, and it has other differential diagnoses, including adrenoleukodystrophy, as we observed in the first case, familial corticoid deficiency, and Sjögren's syndrome. And what is more challenging in this syndrome that there is no genotype-phenotype correlation has been identified, and you can find like same siblings from the same family with the same gene mutation has completely different features of this syndrome. So the prognosis of Triple A syndrome is highly dependent on early diagnosis, and normal lifespan and childbirth are possible, and the primary cause of this is unfortunately a recognized adrenal crisis. So the complication is either the complication of its manifestation like keratoconjunctivitis for elacrima, or recurrent aspiration lead to acute pneumonitis, choking, and death for the achalasia, or autonomic neuropathy and other neurological disturbances, which could lead to mental retardation, ataxia, muscle weakness, and developmental delay, and also complication of the steroid management. So back to the cases to explore more of the features of this syndrome. So actually, this is the second reason behind this presentation, and you might all follow the father of 3 deceased siblings who posted recently in the social media how he have lost his 3 kids due to a recognition of the clinical features of this syndrome, which is very unfortunate. But now I'll tell the story about the 4th child, which is alive, alhamdulillah. So this is 4-year-old female presenting in shock, and she has been resuscitated in other hospital, referred as suspected case of primary adrenal insufficiency to our hospital. And she had recurrent hospitalization many times with similar presentation. And she had family history, as I previously mentioned, of 3 sibling deaths. All had hypoglycemic seizure and all were hyperpigmented. She has generalized hyperpigmentation and abnormal GALE-up presentation. So as you can see here that this is the GALE-up presentation, you can see that she had oral hyperpigmentation, and that's the child with her other sibling who passed before her, her presentation. And this is the child at the time of presentation. She looks very ill, and she is wearing glasses. So again, let's put it all together. Patient presented with recurrent seizure attributed to hypoglycemia, and she had significant family history of early sibling death. She has hyperpigmentation in the child and other deceased children, so this is adrenal insufficiency till prove otherwise. And the clue here is that this child presentation had elacrima. And I remember that child, the father, when I saw that child, the first presentation at Jafar ibn Auf Hospital, his eyes actually speak about his itself. He just want to just want a solution answer for. He said that all my children had elacrima presentation. I just want to solve this issue. Why all my children had elacrima? And actually, he gave us the clue for the diagnosis. So isolated elacrima, and Nisreen might confirm that, is a very rare condition in children, and it's most common early presenting sign of Algrove syndrome, and it's usually past unrecognized. But patient might present with conjunctival injection, and irritation may be the only obvious signs of presentation. And elacrima and optic nerve atrophy both can be considered part of the autonomic dysfunction seen in patients with Algrove syndrome. And how to confirm this is by tumor test, confirm the presence of reduced or absent tears, and it has degrees from 0, 5, 10, and 15. Or this could be diagnosed by orbital CT, or a slit lamp examination might reveal punctate keratopathy or corneal ulceration. So the lesson is that elacrima is the earliest and most consistent feature of Triple A syndrome, and it's considered a critical diagnostic clue for Triple A syndrome in patients with recurrent hypoglycemia, hyperpigmentation, or familial unexplained sibling death, enabling timely diagnosis and initiation of early life intervention. So please routinely ask about elacrima in any primary adrenal insufficiency child or in any family with confirmed diagnosis of Algrove syndrome in other siblings. And this is just the case which we accepted for publication recently. It's regarding this specific case where absence of tears could be considered as a clinical clue for Triple A syndrome. So the other case is 2-year-old male who presented in shock with severe hypoglycemic crisis. He was diagnosed as Triple A syndrome based on primary insufficiency diagnosis and elacrima, later confirmed by genetic testing. And actually, genetic screening for other siblings who had elacrima led to confirmation of the diagnosis of Triple A syndrome in other members of the families, and proper follow-up and to anticipate primary adrenal insufficiency. And this is how the beauty of genetic testing, where we can anticipate the problem before it happens. So the elder sister is currently 15-year-old. She had only elacrima, no primary adrenal insufficiency symptoms. She had normal cortisol, ACTH on early screening. And this showed the diversity of the AAA syndrome features even among patients from the same family. So in this family, we have 2-year-old male presented with CV, primary insufficiency, while his elder sister has only a lacrima and she didn't experience any primary insufficiency symptoms to date. So primary insufficiency doesn't appear to be congenital in patient with AAA syndrome, but it appears with time. And patient usually presented with hypoglycemic seizure and adrenal crisis indicating glucocorticoid deficiency. And that it's a main cause of mortality in patients with AAA syndrome. That's why early diagnosis and initiation of therapy were associated with milder neurological progression. And lifelong follow-up of patients with initial normal or borderline function is warranted. So another case to explore more feature of this syndrome is a 9-year-old child who referred for interpretation of his abnormal thyroid function test. On examination, he has abnormal dark scar on his face attributed to recent trauma, and mother, she claims that is always having dark scars. And he had a lacrima. Upon asking the mother, she said that he has a lacrima, which was the real concern for the mother, but she sought medical advice many times and she was reassured that this is normal. And he was found to have very low cortisol, so management was started. And you can see here, this is the scar in his face, and this is the same child after management. But the issue in this case that genetic testing revealed no mutation. Actually, genetic testing revealed other disease mutation. So the lesson is that hyperpigmentation is the most common sign of primary insufficiency in our population, despite that we are dark skin population, but you can find the hyperpigmentation is very mild in the palms. It could be very severe, as you can see here. It could be also in the foot. You can see also it can be very evident in the oral mucosa, as you can see in this child. It can be in the scars, and even this is Achilles tendon release scars. And you can see, it can be generalized, as you can see in those boys, and it can be also in other siblings as these families. So don't forget the hyperpigmentation. So the other case is 2 siblings presented at different age and diagnosed as primary insufficiency. Both had a lacrima, hyperpigmentation since early age, led to suspected AAA syndrome. But the elder sister has significant difficulty swallowing, regurgitation, choking, and significant loss of weight. And you can see that this is the child, and this is his compared to his sister, who is very emaciated due to severe achalasia, which has been proved by the upper GI studies. So unlike lacrima, achalasia is uncommon disorder and very rare in childhood. And symptoms include regurgitation, dysphagia, weight loss, failure to thrive. So the presentation of achalasia is not that clear. So patient could present with any of these features. So the incidence of glucocorticoid deficiency in patients with isolated achalasia is low. That's why we don't need to ask about feature of adrenal insufficiency in any patient with achalasia. And diagnosis is always by barium swallow or esophagography or manometry and endoscopy. And management include many operations, including pneumatic dilatation, anterior cardiotomy, as you can see in this curve. So the lesson here is that endocrine evaluation is not warranted in patients with isolated achalasia unless there is symptom suggestive of glucocorticoid deficiency present, unlike lacrima, because lacrima itself is a very rare condition. So the 6th case is a 5-year-old male who referred from neurology department. He has been followed for the past 3 years as a case of global developmental delay, but recently he developed convulsion, and in the past 1 month he developed hyperpigmentation. That's why the neurology department, they thought about adrenal dystrophy, and but upon history that he was found to have a lacrimal synspairs, delayed teeth eruption, and global developmental delay. So as you can see here, the child has features suggestive of Algrove syndrome. He has long ears and large long philtrum as well. So what about the neurological manifestation in patients with Algrove syndrome? The pathophysiology actually is not well known, but it's really variable and progressive with time, including central, peripheral, and autonomic nervous system. And patient might present with other features, including gait disorder, Parkinsonism, and myoclonus. And it's due to neurodegenerative process in 60% of the patient, and maybe among the presenting features in patient with AAA syndrome, as you can see in this child. Seizure have been described, but usually it's due to hypoglycemic seizure, and patient might develop developmental delay. So another case, which is very interesting because it's the first case that pointed towards other features, at other unreported features of this syndrome, actually. So this 13-year-old female who had normal development up to age of 5 years, and then he started to develop excessive nasal secretion. And he had abnormal gait and difficult walking. He had lacrimal nodes since birth, and he had hyperpigmentation, which passed unnoticed by the family, and it was not the concern for the family at presentation. So after 5 years and at the age of 10 years, this patient presented with dysphagia, difficulty swallowing, which got worsened, and he was unable to walk unsupported. The MRI brain is normal, and actually this child has been like mingling around different clinics, and even they went abroad to the Egypt just to solve the issue of excessive nasal discharge. So they were not so concerned about the hyperpigmentation and others. So at the age of 13 years, this child presented with fever and hypoglycemic convulsion. His random was very low at presentation, and the hyperpigmentation likely has been picked by the caring doctor and suspected pyramidal insufficiency, and then sent to us. And I remember that case was from Durman, and thank you for Dr. Hiba who referred this case at that time. So on examination, this child is very calm and has depressed mood. He has low cortisol, high ACTH, supporting his pyramidal insufficiency diagnosis. He has normal electrolytes, and shimmer test is positive, supporting lacrima. So this is the child at presentation. And actually, this family are very lucky also because we were able to pick the sister of this child, the other sibling of this family who had also hyperpigmentation. Not only the girl, but they have also younger sibling who was 3 years of age who had the similar presentation, and genetic testing revealed Algrove syndrome in the whole siblings. So what about the neuropsychological disturbance in patients with Algrove syndrome? They might experience some mild intellectual disability, maybe attributed to hypoglycemia. They have some low IQ and impaired intelligence, and anxiety, affective mood disorders, and this is really progressive and should be evaluated regularly. That's why those children need a multidisciplinary team at presentation. So the message from this case is Triple A syndrome should be part of differential diagnosis in any cases with early neurological dysfunction and developmental delay in pyramidal insufficiency cases. Anticorticoid supplementation does not seem to affect development and course of the neurological symptoms. That was what was reported in the literature. But from our experience in Sudan, we found that early initiation of glucocorticoid therapy have been helped other siblings in actually prevent some neurological manifestation. We have been observed that those patients who have been initiated in glucocorticoid therapy has delayed neurological presentation compared to their siblings who had early presentation due to frequent hypoglycemic seizures. And physiotherapy sessions might help to improve the patient who experienced the neuromuscular symptoms. And the last case is 3 siblings. And those also are very interesting siblings because they presented with different also rare presentation. They presented with at different age and diagnosed as pyramidal insufficiency. So at first presentation, they have been diagnosed as Algrove syndrome, as you can see here, but they have electrolyte disturbances suggestive of salt loss with low sodium and high potassium. And these are from few reported cases with mineralocorticoid deficiencies reported in Algrove syndrome patient. Actually, in our series in Sudan, we have found that 15% might develop defective mineralocorticoid production. That's why they need further cortisone management. And part of the surgery remains unknown, but it looks slightly due to progressive zona glomerulosa degeneration associated with adrenal dysfunction over time. So those siblings, and actually they are from Port Sudan. If Dr. Suhair is here and Dr. Amal, they are the ones who diagnosed this case. So after a few years, those siblings developed fever, headache, and convulsions for 3 weeks, interpreted as meningoencephalitis at first presentation. And they were very ill, unconscious, and febrile, and both are severely hypertensive. And even one of the children experienced sudden loss of vision with pale optic disc and partial optic atrophy and cortical blindness, and MRI showed cortical degeneration. So the questions in this case at that time was, what was the cause of the neurological features in both siblings? And if we consider it as part of its meningoencephalitis, why did they develop the same feature at the same time? And if it's part of neurological manifestation seen in patients with Triple A syndrome, why did they present with it at the same time? That was really a dilemma in this case. And could it be part of autonomic dysfunction seen in patients with Triple A syndrome? I mean the hypertensive encephalopathy. So autonomic dysfunction is found in a third of patients with Algrove syndrome. And the symptoms are various, including postural hypotension, orthostatic hypotension, among others. But hypertensive encephalopathy have been reported in the literature in some cases. Actually, I found just only one report supporting our report of patient with hypertensive encephalopathy in patient with Triple A syndrome, and it's very difficult to be managed. And actually, we lost one child from this family. So other presentation of patients with Algrove syndrome include dysmorphic feature, as we mentioned before. They have very specific and very specific nasal speech of voice. If you can see all patients with Algrove syndrome, they have this kind of nasal speech tone of voice. They have excessive thick nasal discharge, which is the newly reported symptoms in our series. And they have also some might have delayed speech, delayed puberty, whether due to malnutrition or others, and they have complication of management itself. And if you can see, this is one of the children. He has excessive nasal discharge. He has some dysmorphic features suggestive of Triple A syndrome, long ears, and so. And he has fisher tongue suggestive of Triple A syndrome. So there are some management consideration in patients with Triple A syndrome, like how we should guide the treatment. As we mentioned before, that we should give just the physiological doses of glucocorticoids, and extra or supraphysiological doses are not indicated in patients with Triple A syndrome. And if patient presented with mineralocorticoid deficiency, then replacement is indicated. The eye care is very important, and the follow-up is also very important to pick the other features like the neurological features. So regarding the situation worldwide, if you can see here, that there are many reported cases worldwide, but in Sudan, before 2017, there were no reported cases from this syndrome. That's why we thought that we should report our cases from Triple A syndrome. That's why we reported these cases like just recently in 2025. And we have found that in this report, we reported 48 patients from 32 families were reviewed, of which 31 patients from 20 families had genetic testing done and confirmed the Triple A syndrome with 6 different mutations and 2 novel mutations reported. And we found that hyperpigmentation is the main cardinal feature presented in more than 95% of cases, while alacrima is a consistent universal sign that present in all cases at presentation. Actually, 100% of cases had alacrima at presentation, and this is considered the largest reported cohort of Triple A syndrome to date from worldwide. So this is just considered the tip of the iceberg. We know that we had many undiagnosed cases, and just in the period of the war, we had more than 6 patients diagnosed after this report. So if we look at the clinical genetic profile, we can see that the alacrima is the main feature, followed by hyperpigmentation, and we had many genetic mutations, including 2 novel ones. And if we want to put that in numbers, in our cohort, we have consanguinity more than 80% in our cohort. 70% had family history of similar condition at presentation. And actually, there are very long duration of symptom for diagnosis, including more than 1 year in 40% of the cases. And 40% of cases has family history, unfortunately, of sibling deaths with similar condition. And 70% has history with recurrent hospitalization and other diagnoses. And also, 70% has other diagnoses, 40% have other diagnoses like malaria, meningoencephalitis, or gastroenteritis at the time of presentation. So what are the challenges in Sudan that we face? We have poor healthcare system, as you know. We have lack of awareness and diagnostic facilities and their cost. And we had also patients who usually presented very late in severely compromised status. Medication supply is also an issue, including the hydrocortisone and fludrocortisone. And we have lack of multidisciplinary team rehabilitation service for those who develop neurological symptoms and other complications. And there is no consensus guidance for the family and for the physician on how to follow up those patients in our setting. So what's next? What should we do regarding this? What we did actually is to start where we are and use what we have and do what we can so as to achieve our goals. So our achievement in the period is we can do the patient's registry. Now we have registry of those cases. And also we had patient support group, and actually that have been initiated by the father of the girl, Abu Rajaj, who had the 3 sibling test, and he had been communicated with other patients and families worldwide, including other families with Algrove syndrome in Saudi Arabia, Algeria, Tunisia, and others. And we need guidelines for follow-up of these cases. Also, establishing a multidisciplinary team. It's not, I can't say that we have established a multidisciplinary team, but we have very good connection with other team members, including the psychiatrist, Dr. Khalid. Nisreen is here. She's the ophthalmologist following up those patients. And also, we supported investigation and like genetic testing and medication supply for those patients in some patients up to date. And we had also a very good international collaboration, actually, that helped to support genetic testing for those patients with Algrove syndrome. And these have been initiated since 2017 up to now, up to date. And we have to raise the awareness. And regarding raising awareness, we've had many presentations in different international platforms and local platforms to raise the awareness about Algrove syndrome. And for those who don't know Algrove syndrome, this is Jeremy Algrove. I met him 2017 in US, where I expressed my interest in collecting these cases, and with the support of Prof. Ahmed Abdullah. And we have communicated with Prof. Angela Hubner. He's the one who is doing up to now genetic testing for free for our patients. And this is just Jeremy Algrove last year, where I met him in the last SP meeting. So just to close this presentation with very good vibes. And this is the picture of Ritaj at presentation. And this is the picture of Ritaj after discharge from the hospital. And this is Ritaj now. And this picture actually has been with the father has allowed to share this picture. Actually, he's sharing this picture everywhere to raise the awareness about this syndrome and to raise the awareness about how early management could lead to better outcome. So in conclusion and take-home message is Triple A syndrome is the most common etiology of primary insufficiency in Sudan, with wide range of variable presentation, even in the siblings from the same family. And it should be suspected in any child with elacrima and hyperpigmentation. And elacrima is the cardinal features presented in all patients of Algrove syndrome in our setting, which usually noticed by most of the patients since birth. So raising awareness is essential, needed to early detection of these cases and early management. And this is considered the largest cohort of Triple A syndrome reported to date. So I just want to close with this. If you see child presented with elacrima, achalasia, adrenal insufficiency, and autonomics or neurological dysfunction, just remember Algrove syndrome. So I want to acknowledge the patient and their families, and Prof. Ahmed Abdullah, who is the one who established the pediatric endocrinology service in Sudan, and my colleagues at Jafar ibn Auf Hospital, who helped a lot in raising awareness about this condition and collecting these cases with me, and also the international collaborators, Prof. Angela Hubner and Catherine. And thank you very much for listening. And we hope that we can gather again in Khartoum, inshallah ta'ala, very soon. Thank you very much.
Thank you, Dr. Selwa, for this, I would say, well done, well prepared presentation, which took us on a journey, not only for raising awareness about Algrove syndrome and among our pediatricians, but giving us that not that scientific knowledge and evidence-based and dedication of work that you and your colleagues did all over those years. It's really took us toward a journey of advocacy of patient care and upscaling services and international collaboration. Thank you very much for this, and I would open the session for a few questions, if the time allows us. Anyone have a question, you can just put it on the chat, or even you can raise your hands for the questions.
السلام عليكم. أنا دكتورة نسرين. بس عايزة أضيف
Yeah,
شوية.
Dr. Nisreen. Yes, Dr. Nisreen, go ahead.
Yes, Ahmed, before Nisreen talk, Nisreen is the pediatric ophthalmologist. who is like he have helped a lot in diagnosed lacrima in those cases, and she's supporting us a lot in diagnosing lacrima in these patients. Thank you very much, Nisreen.
Thank you very much. We are doing teamwork to save life and vision of children. طيب بالنسبة للألجروف syndrome, lacrima is one of the important sign and symptom. Swimmer test is very simple test. It is available. It is a strip from 0 to 5. It can be alacrima or hypolacrima. Very simple test can be done to save vision and save life. When diagnosed adrenal insufficiency as primary or secondary non-arthritic anterior ischemic optic neuropathy that can lead to optic atrophy, so leading to vision loss, also is an important sign. Cortical blindness, also due to hypotension, so decreased perfusion to the visual cortex, also lead to blindness. So anterior segment and posterior segment both affected by adrenal insufficiency. One of the important manifestation, hyperpigmentation. Hyperpigmentation can be around the eye and in all mucosa. So hyperpigmentation can be seen from entering the patient from the door. So when we put adrenal insufficiency in our mind, we can diagnose hyperpigmentation, alacrima, and optic atrophy. All this can lead to blindness. So ophthalmological assessment is an important pathway in the investigation and management. Thank you.
Thank you very much, Dr. Nisreen. Thank you very much. That was very enlightening. And again, having the multi-D and multidisciplinary approach is really well appreciated on those cases. There is 3 questions on the queue. I would start with the first one, and I will ask Dr. Selwa to answer. Is there a link between excessive nasal secretion with AAA syndrome in the case presented?
We couldn't find the pathophysiology of this. It could be like one of the part of autonomic dysfunction seen in those patients, but we couldn't elicit the pathophysiology behind this. Actually, it's because it's like very new symptoms we reported. And actually, it started just with one case, and I started asking another cases if you have like experienced, and they just, how did you know? Yeah, they just tell me, how did you know? We have experienced excessive, it's actually very annoying for the family and for the child itself. It's very, very annoying because it's very huge and massive excessive nasal discharge. And when I've started to ask other patients about these symptoms, I found like 25% of our cases have this feature of excessive nasal discharge. And when I reported this to Prof. Angela, who is the genetist who is collaborating with us, he couldn't have an explanation. We're just working towards knowing what's the pathophysiology behind this, but mostly, most of the feature of Algrove syndrome is due to autonomic dysfunction observed in these cases.
Thank you very
أحمد، أنا ما
much.
عارفة الباناليست اللي معانا في بروف أحمد أعتقد ما عارفة إذا موجود في دكتور عمر if they want to comment on this.
Give any comments? They are more than welcome, as sure. Okay, if there is no other comments, because there is a queue of questions, which is like, I think it's a shower of questions now. Okay, considering the neurological manifestation in Algrove syndrome may continue to progress despite adequate glucocorticoid replacement, should we view Algrove syndrome as primary, as adrenal disorder with neurological complication, or rather as a progressive neurodegenerative disease in which adrenal insufficiency represent only one component on a broader pathology? Dr. Adel
Very
Nair,
nice.
I think.
Yeah, very, very nice question. Actually, it can be both because, in a places where picking early these cases, then this could be attributed to manifestation of this syndrome because, as we mentioned, that Aladdin protein is expressed in the brain cells as well as the adrenal cells. So the neurological manifestation is a part of this syndrome. It's not due to just glucocorticoid deficiency or hypoglycemic seizure. Okay, but in our situation, that could be like double effect. It could be due to this part of this syndrome and could be also one of the complication of late presentation and multiple neurological, multiple hypoglycemic seizure. But our observation from our series that when we initiate the glucocorticoid therapy early in families with different siblings with triple A syndrome, we have found that those who have been initiated early on the glucocorticoid treatment have less progression in the neurological symptoms compared to the sibling who presented late with neurological features, and then the management won't help much in that, in that perspective. So it is still, it's still, unexplained, but how glucocorticoids could help. But the theory is it might help in preventing the hypoglycemic seizure, which could lead to other neurological sequelae in patients with triple A syndrome.
Okay, building on that, there is other question which is related to this, which is, are there any signs that we should be actively looking for neurological involvement?
What? Can you repeat, Ahmed, معلش?
Is there is any sign that we should be actively looking for in regards to neurological involvement?
Okay, the neurological symptoms actually in patient with triple A syndrome are very, very broad, So it's very broad. It affect the motor, the sensory, the autonomic nervous system. So they could present with developmental delay, with sensorineural deafness, with whatever manifestation. So it's really very broad. But what we have observed in our patient that they usually presented with gait abnormalities. Okay, so this is the first feature that we have observed in many of our patients. They have some gait abnormalities at presentation, in addition to the developmental delay, which could be attributed to severe hypoglycemic seizure as well.
Thank you very much. There is also two related questions, which is, what is the common age for presentation? And is the hyperpigmentation should be over the palm and sole, mucous membrane, or just on the area raised our concern toward adrenal insufficiency?
Okay, so our first series of parameter insufficiency, where hyperpigmentation had been present in more than 98% of cases, and it's the main feature of presentation for patients with parameter insufficiency, the hyperpigmentation is usually generalized. And despite that we are like a dark skin population, still the hyperpigmentation could be very evident. But the easiest ways to look to hyperpigmentation is the palms and soles, and compare the palms to the parents' palms as well. It could be also found in the soles, in the oral mucosa, and also in the scars. As you can see when I presented those cases who presented with scars that is very hyperpigmented. So it can present anywhere, but the most common is generalized hyperpigmentation. Patient, maybe that's due to late presentation, maybe, but we have observed that our cases present usually with generalized hyperpigmentation.
And the common age for presentation?
It varies, because it's multi-system syndromes. So each feature of this syndrome can present at different age. Usually lacrima usually present at birth, either lacrima or hypolacrima. It's consistent feature that's present since birth. It might be observed later, but it's present since birth. The adrenal insufficiency might be present in the first or second decade of life, but in our series, most of the patients, like 70% of patients, presented less than 10 years of age. Okay, so this is considered as early presentation compared to other, other series. And achalasia is found only in 1/3 of the patient. So, and usually it has late presentation after the 2nd or 3rd decade of life.
There is another question is, what is the specific genetic test that you has been done?
Usually we are sending like a specific signal sequencing for the triple A gene, AAS gene. But when we didn't find, like if we didn't find like a specific, we do WES. But I just want to reassure our colleagues in Sudan that for triple A syndrome, genetic testing is offered free of charge. You know, we had this international collaboration with this lab in Germany, and actually, Prof. Angela, she's the one who is doing the genetic testing for Algrove syndrome worldwide for most areas of the world. Okay, so she's very expert, and we had very nice collaboration with her for exome sequencing. Yes.
Thank you. There's another question about the treatment for achalasia in Algrove syndrome. Is it just corticosteroid?
No. It's not the corticosteroid. It needs dilatation, you know, either pneumatic dilatation, or sometimes they might underwent like open surgery to dilate. But unfortunately, for those cases who experienced achalasia, some of patients, because it's some part of autonomic dysfunction, it might recur. This is the issue. But those who underwent like operation for achalasia have shown like very nice improvement in terms of like weight gain, in terms of puberty and height gain. So in terms of growth, they showed very good result.
Okay, I think we left with the last question. In patients with alacemia and achalasia, but normal adrenal function, how frequently do you recommend screening for adrenal insufficiency, and for how long should follow-up continue?
Okay, so as I previously mentioned, we can do the cortisol, like we can do screening test, just early morning cortisol every 6 to 12 months, okay, to anticipate. But we need to teach and educate the families about the early symptoms of adrenal insufficiency, like if the child is developing any kind of hypoglycemia, if the child if you notice any kind of mild hyperpigmentation in the child, if the child develop any like vague symptoms of primary insufficiency, then they should come immediately. But if not, then we can follow the child every 6 to 12 months with early morning cortisol.
Thank you. And there is another question. Can we start hydrocortisone when serum cortisone in the gray zone for better outcome related to neuro issues?
No, it's not advised. We just need to monitor those patients. And in patients who have like borderline cortisol, we need to do synapsin testing. So as we ensure that the adrenal reserve is very good. If the cortisol is okay, then no need for like early unnecessary treatment for patient, just to preserve because we don't need to forget the side effect of the steroids.
There is also one question here. Can patient present only with hyperpigmentation without alacemia or achalasia?
Okay, so in our series, alacrimia is found in 100% of patient presentation. Okay, so it's there. And then the adrenal insufficiency develop later. But in other series, alacrimia was found in like 80% to 90% of cases. So that means that some cases couldn't present with alacrimia and might present with adrenal insufficiency only. Or it might be يعني hypolacrimia. Okay, that would be very difficult to differentiate from the normal tear production in those patients. So it's either alacrim or hypolacrim.
What is the treatment when the patient coming in shock and he or she is known case of TS?
Okay, so that means when the patient presents with shock, that means that this child is having the adrenal crisis. And this is this needs a very acute management. So we immediately need to give this child hydrocortisone, stress dose of hydrocortisone immediately. It depends on the age of the child. In smaller children, it could be 25. In the older children, it could be 50 and then 100. So it depends on the age of the child. We should give the hydrocortisone immediately, either IV or IM. Then after that, we need to give this child, because this child could be in hypoglycemia, then we need to give 2 ml per kg dextrose 10% to manage the hypoglycemia. And then because we don't know if those children had mineralocorticoid deficiency or not. If the child just present with shock, just give the IV fluid so as you can preserve the mineralocorticoid pathway. So it's an acute management, and then you need to put that child on regular steroids. And if the child doesn't, it's the normal management of shock. But here you just need to give the hydrocortisone, the dextrose, and the fluid.
Thank you very much. There is, I think it's a comment from Dr. Bahadin, who is thanking Dr.Selwa for the great work, and remind all the people here and ourselves for acute pediatric problem. In acute pediatric problem, that our differential diagnosis should go for exclude serious, think common,
Condition.
and look for the rare. Always don't look for the number, look for the patient behind this number. Thank you, Dr. Bahadin, for this very important comment.
And just I want to highlight, yeah, Ahmed, there are many other common etiologies for patients who presented with hyperpigmentation in our setting. So patients with B12 deficiency, they might have hyperpigmentation. Those with celiac disease, those with malnutrition might have hyperpigmentation. But the most important thing, as Dr. Bahar mentioned, is that we need to exclude the most urgent and common and dangerous etiology, which is the pyramidal insufficiency, before thinking of others. If you exclude pyramidal insufficiency, then we could think about other causes of the hyperpigmentation and other etiologies.
Okay, I think we left with, for the sake of time, we'll be closing with this question. Can it present on third decade with just hyperpigmentation of palms and autonomic, which is high blood pressure?
تاني معلش يا أحمد.
Can Algrove syndrome, I suppose it's Algrove syndrome, present in the third decade just with hyperpigmentation of palms and autonomic, which is high blood pressure?
Late presentation of Algrove syndrome have been reported, but usually patients have a lacrima, So late presentation, there are some reported late presentation of Algrove syndrome, but usually patients have other features supporting this late presentation. It can't be just, just hyperpigmentation and autonomic dysfunction. We need to look to other triad of Triple A syndrome. And even if the patient is having hyperpigmentation, then we need to confirm if this hyperpigmentation is related to primary adrenal insufficiency or other kinds of hyperpigmentation. If it is primary adrenal insufficiency, then yes, this is primary adrenal insufficiency. Then we have to look to other causes of primary adrenal insufficiency, because the hypotension and other features could present in autoimmune Addison, for example. Okay, so we need to know the cause of primary adrenal insufficiency. We need to confirm the primary adrenal insufficiency first, and then look for the cause of primary adrenal insufficiency.
With this, I'm really صراحة thankful for Dr. Selwa for giving this very nice presentation. And for the sake of time, I would like to conclude the questions, and I would give it back to Dr. Karim and Dr. Taha for handing over the session. Dr. Karim?
Karim is mute, I think.
Okay.
Dr. Karim, can you open your mic, please? Okay, I think Dr. Karim is away.
Okay.
Dr. Umar, you have any comment?
طيب شكرا لكم كثير. والله بدي اقول لكم كومنت انا هقول لسلوى، يعني thank you so much for the very elegant presentation which touch كل الجيرني، ويعني I think it's very educational لنا كلنا وبالذات للريجسترار. Yes, thank you so much for all of you and for this Selwa in particular. Thank you.
شكرا يا عمر.
Thank you very much. And I would remind the people, please, all the attendees, you need to fill the form which is sent by the ISAP.
Yes,
Please make
feedback
sure.
form.
Yeah,
Feedback
please
form.
make sure that you fill the feedback form, because this will help the people to go on and on again on such presentations and such educational activities. And I would like really to give at least 2 minutes before we close the session to make sure that all the people fill the form.
Thank you, Dr. Ahmed. Meanwhile, in these 2 minutes, we're just and we thank all of you from Oman Group for presenting for us this very important presentation and sharing of experience. And definitely, this will motivate more people to come forward and also share their experiences. Today, this was the first meeting after formation of the ISAP, the academic branch. We hope it will continue. And just to remind everyone that these sessions are recorded, it will be in the YouTube channel. And we also will arrange every Saturday. Just be reminded that the time zone are different because of limitation of time in different countries. So just not to miss the session, make sure that you read the time correct and be on time for attending the session. Thank you very much. We really appreciate your coming today. And on behalf of our organizing committee, we thank you all and see you next week, Saturday, with another session from another country and sharing of experience. Thank you very much.
Thank you. Thank you, Ahmed. Thank you, Muhammad, Dr. Karim, Dr. Taha,
Thank
for
you.
this nice organization. And hope that these academic activities could be continued. And thank you for the audience. Thank you very much for the whole comments, and hope to see you soon again, inshallah ta'ala. Thank you very much.
Thank you very much. Assalamu alaikum.